I would like the first speaker, Dr. Hazra, to present the first 500 cases implanted in India.
Myself, Dr. P.K. Hazra from eastern part of India, will be presenting site-reported clinical outcomes of first 500 MeRes100 implants in Great India. This evolution, everybody knows, from balloon to stent, stent to BRS, then BRS to stent, again stent to BRS. That is the spectrum of our understanding of scaffold, stents and devices inside the coronary artery. In last 17 years, the ISR rate has become almost a fixed number, 10.8%, all over the world. So ISR will happen whether you have the best stent or thick stent or thin stent, but the acute complications like stent thrombosis, death and mass is of utmost importance. Safety is utmost importance. So thickness of the BRS is very, very important, and we are able to reduce the thickness to 100 micron with MeRes. And this is none other than a proud Indian product, MeRes100, which is a closed cell and open cell hybrid cell design, which is PDLLA sirolimus 1.2 microgram per millimeter square, unique design and unique profile. Now, if you understand the stent which we are putting in the past, we have some stent where the balloon is exactly on the marker, like Giant series. We have stents, most of the stents except Giants, they are away from the stent edge. And our unique MeRes, there are two radio-opaque markers. The distance between the distal edge of the balloon and the marker is 1.3 millimeter. Extra scaffold available beyond the arrow marker is 1.2 millimeter. Balloon overhanging is 0.1 millimeter. So this is a unique stent and unique design. And if you compare with other drug-eluting stent, is very close to the modern second generation drug-eluting stent like Gonix 4.5, which is 91, and we are almost nearer to the about Encore BRS in 95 micron, which will be available very soon. Now, the crossing profile is excellent, and we have different sizes, and we have MeRes100 trial publications, 3-year clinical and 2-year multimodality imaging outcomes of a thin strut sirolimus vascular scaffold MeRes1 trial. We have Dr. Praveen Chanda, we have Dr. Seth and other people. So in the podium we have Dr. Chandra, and you can have his experience with this unique BRS. And we have also 3-year imaging data from Alexander Avizade from Brazil. What we have seen, the MACE rate is single digit, very nominal. Cardiac death rates almost zero. Cardiac death is zero. MI is zero. We have non-cardiac death 1, and in cumulative clinical outcomes up to 3 years, very, very robust data. Though the number is very small, you do not have very high statistical power, very high confidence interval. Even then, it is a humble beginning of this new technology. So conclusion from MeRes1 and MeRes1 Extender, that the novel second generation MeRes100 with 100 micron start thickness demonstrated high acute success as well as long-term clinical success up to 3 years. By 2 years, most of the this BRS stent is dissolved. We have 1 more extra year in patients with single de novo lesions, demonstrating very low MACE rate and zero scaffold thrombosis. All imaging modalities are consistent in demonstrating high efficacy, disappearance. The late luminal loss was very low, complete start coverage. IVAS analysis revealed sustained mean flow area, and encouraging results of these clinical trials provide the basis for further studies. And we have completed 563 implants from January to last December, And we have total number of patients, which is 479, almost 150 operators, centers in India. Is the pan-Indian presence, pan-Indian experience, and our experience is very sweet experience. Most of the BRS is LED, most of them are single stent, most of the stents are 24 millimeter and 3 to 3.5 millimeter in diameter. Now, the advantage of introducing this technology in India after a long lull is that we get 2 bonus balloon for pre and post dilatation that comes as a package, and the price is quite affordable, attractive, and now it is available across the country. We have the metrics from 2.75 up to 4. We have metrics from 16 to 40, and this complete package is available in most of the hospitals in India, and this is quite attractive commercial offer from the industry. Now we have cumulative MeRes, only 3 patients, 0.6%. Cardiac death not directly related to stent. This non-cardiac, they died later on due to comorbidity. Myocardial infarction is 0, TLR is 2, and out of these 2, I have only 1 patient. I have 1 patient who developed a tight ISR of the proximal LAD. I could tell you that the bed preparation was not good because of fibrocalcific. Patient actually wanted BRS this time when they came to know that this device vanishes with time. So doctor's mother, anyway, this patient has undergone CEBG later on because they wanted CEBG at the bifurcation of LAD-D1, 111 Medina. Acute scaffold thrombosis is 2. None of my patients had acute stent thrombosis. The distal LAD looks not so significant in a borderline case. Once we got the confidence of patient-oriented outcome and device-oriented outcome from MeRes100, I was very confident that this man needs a device in the distal LAD where you put a metallic stent. The surgeon may have a problem in the future. 58 male, non-diabetic, CCS class 3, and he had some tight lesion in the circumflex, non-CKD, low bleeding risk. So these are very important before you contemplate MeRes or BRS in the human coronary. Simple PTCA to circumflex, tolerated aspirin for pretty long time, non-calcific and simple coronary artery. And then we decided to put BRS, but as we are discussing, the acute stent thrombosis is tolerable and safety is quite okay. DAPT is okay for this patient. But if you put BRS or MeRes100, you have to think about the cost of the device and the lengthy procedure along these radiations and the dye, and the cost of the imaging is additional burden. So you may agree with me or may not agree with me, and we always do some kind of imaging. In this case, the IVUS was not great, and it shows fibrocalcific lesions. And then we took the OCT. The OCT pullback again showed very tight stenosis in the distal LAD. And then we did the physiological thing, whether he needs stenting or not. If you see this chart, it was 0.84 pre, 0.89 post, and 0.96 after optimizing. When you do IFR in the diffuse LAD or a long LAD, you must remember the 30 millimeter dead space of the IFR were in distal disease, unlike microcatheter-based IFR. Even then, the IFR was positive. I gone ahead with the implantations of a BRS, pre-dilated, 2.75, 15 millimeter lineage balloon at 12 atmosphere. Then bed was prepared. Then, we put the MeRes100, and this MeRes, the beauty is you have very distinct marker. So if you are overlapping, this much easier, and you have around one stent start beyond this marker. So if you put a Mercedes-Benz sign here, you have 2 dots here, 2 dots here. In OCT is nicely visible. Most of the time, we inflate this stent with a timer, but recently we have started doing this thing just by counting 1,000, 2,000, 3,000 up to 10,000 for 1 atmosphere. Then you again repeat 1,000 to 10,000 counting, the verbal counting up to 2. So such way you go to 4, then 1,000 to 5,000 up to 8 atmosphere, then inflate up to your expectation. So it's very, very easy to implant. And once you see this, you're very happy that your device, whatever you may call it, is nicely placed, and you are confident that after post-dilatation, you will have a good flow, good OCT image of MLD max, which we have done, and it will take a long time to show this, but I was quite happy with the post-optimizations OCT images, MSA. There is no dissections, there is no interluminal narrowing. So imaging is must, and P-op as a pre-dilatation, post-dilatation is a must. Have some patience because in some cases you may face some difficulty in pushing, but too much of pushing can embolize the stent like any other stent. So be patient. So prepare the bed. It should be avoided in the first few cases of tortuous calcification lesions, primary angioplasty. So this is the result of your MeRes in my case. And with that, I'd like to thank for giving me a chance to speak. Thank you.
I think this is one of the very, appropriate usage of MeRes, especially in the distal LED segment, which is the target for future lima grafting. And that is what we have been, discussing since the very onset of these bioabsorbable scaffolds. So thank you very much.